This is a case example of a large posterolateral branch where no other branches were seen, and although it's easy to put the lead in, the results can be difficult due to phrenic pacing, lead stability, and an apical location with a short QLV. So this is the branch, and as you can see, it's a big, large branch with some distal side branches. And so it's important to resist the temptation to throw in a lead and hope for the best. So we started off with the vertebral shaped vein selector paired with the 5.5 French renal LVI. And once we were in with the vein selector, we injected the branch itself, looking for other options to see what else might be available should there be phrenic pacing and high thresholds. And you can see that there are side branches that weren't apparent on the occlusive venogram, and most appealingly would be this branch down here. And so we put the lead into the main body, and as you might expect, there were high thresholds and phrenic pacing, and the QLVs at best were in the 80 millisecond range. So because we had the sub-selector in the branch shown here, we had options. If we just tried to pull the lead back, it would slide forward again, or if we pulled the slack out, then it would slide out of the vein. So remembering that there was this side branch, we were able to go after this side branch. And we were able to then just slide the sub-selector back, put the lead inside the sub-selector, slide the sub-selector back until the tip of the renal LVI approximated the side branch. And you'll notice that the LVI is actually angled towards the side branch. And then we were able to advance a wire into the side branch. Now, if we had any difficulty advancing the lead into the side branch, we could have taken, or the wire into the side branch, we could have taken the wire, or the pacing lead and the wire out and put a vertebral in to select the side branch. But now we're in a situation where we need support to advance the lead into this smaller side branch. And we have the sub-selector positioned at the os of the side branch, which will provide support. But importantly, we also have the sheath, which is stabilized by an Amplatz wire. So the sub-selector is stabilized, and we're able to advance the pacing lead deep into that side branch where there was no phrenic pacing. The QLV was excellent, and because it's in the small side branch, nice and stable. So interventional tools and techniques made it easy to take control and get a good result. Unfortunately, you can't rely on device companies to provide everything you need. If you want to take control and stop feeling like a victim of the anatomy, you must make an effort to acquire the tools and learn the techniques of interventional CRT. When you do, your implant times will decrease, your lead positions will improve. As a result, you will start to enjoy CRT. And this is the equipment list that I strongly recommend. Each and every one of these items here I find to be essential, and this includes what you need to do, what you need for the snare technique. And the choice of wires is not random. Each one of these wires turns out to have a very specific purpose. Hope this finds this helpful, and again, I think it's worth the effort to get the equipment.